Good morning, my dear students. Today we are going to discuss about what is peritonitis and what are the different types of peritonitis. And I am Dr. Prasad Paul in the Department of Surgery to deliver this lecture. So peritonitis is nothing but inflammation of the peritoneum. So peritoneum has got two parts. One is the parietal peritoneum, the other is the visceral peritoneum. The parietal peritoneum is pain sensitive since it has got a rich supply of nerves, whereas the visceral peritoneum, because of the poor nerve supply, the pain is not localized, it is a vague pain. So peritoneal cavity is the largest lined cavity in the human body, and it is lined by a single layer of polyhedral cells. The peritoneum contains fluid which is pale yellow in color, which is viscid, and its function is lubrication of the viscera as well as absorption, the principle which is being used in peritoneal dialysis. So the direction of movement of the peritoneal fluid is towards the diaphragm during expiration. So whenever the diaphragm descends during inspiration and the diaphragm ascends during expiration, so the movement is more towards the diaphragm, and this may be the reason cited for the evolution of the subphrenic abscess. Peritoneum can absorb large volumes of fluids. The principle, as I mentioned, already being done in case of peritoneal dialysis. Peritoneum can produce inflammatory exudates on different sorts of injury, like a bacterial infection in acute appendicitis, a chemical injury following a biliary peritonitis, ischemic injury following strangulation of bowel, or a direct trauma during an operation, or maybe an allergic reaction due to starch peritonitis. So once the peritoneum is injured, the healing doesn't take place from the edges just like any other epithelium, but is by the development of new mesothelial cells. Now peritoneum, I mentioned, is the inflammation of the peritoneum. So peritonitis can be acute or chronic. The most common is the bacterial peritonitis, usually caused by a variety of organisms, usually it is polymicrobial, except for some cases of primary peritonitis by H. influenza, pneumococcal or streptococcal. So most common form of peritonitis is bacterial peritonitis, and it is mostly a secondary peritonitis due to some cause secondary to, like peptic ulcer perforation, an intestinal perforation, and appendicular perforation, like that. So bacteria in peritonitis, the major source is the GI tract. It could be E. coli, streptococci, bacteroids, clostridium, klebsiella, or even staphylococcus. Other sources may be chlamydia, gonococcus, beta hemolytic streptococci, pneumococcus, or even mycobacterium tuberculosis. Non-gastrointestinal causes of peritonitis may be by fallopian tubes producing a pelvic infection, or in immunosuppressed patients, like in acute acquired immunodeficiency syndrome or immunosuppressive treatment or even a Mycobacterium avium intracellular infections. Coming to the root of infection, it could be a gastrointestinal perforation like a perforated peptic ulcer, or maybe an exogenous contamination via drains, open surgery, or trauma. Or it could be by transmural bacterial translocation, which can happen in intestinal obstruction, ischemic bowel disease, appendicitis, or inflammatory bowel disease. Pelvic inflammatory disease of the female genital tract, that is one source or root of infection. And of course in septicemia via hematogenous spread. Now peritonitis can be either localized or diffuse. Now, what is the reason for localization of peritonitis? Could be due to the different anatomical spaces, could be pathological, or maybe due to surgical drains. So these are the reasons cited for localization of peritonitis. What are the reasons for development of diffuse peritonitis? The diffuse peritonitis may be attributed to the speed of peritoneal contamination, for example, perforation proximal to obstruction, or a sudden anastomotic separation. And this is aggravated by peristalsis, the stimulation of peristalsis, which can produce a diffuse peritonitis. The virulence of the infecting organism, young children where the omentum is not well developed, so the abdominal policeman is not coming into action. Disruption of the localized collections by rough handling during surgery, and in immunodeficient patients like old age, steroids, diabetes, or AIDS. Coming to the clinical features. So, localized peritonitis, the most prominent feature is abdominal pain with the localized guarding and rigidity. There will be tachycardia, there will be vomiting, the temperature may go high, and when you examine the abdomen, the patient might be having a localized guarding and rigidity, rebound tenderness, which itself is a feature of the inflammation of the parietal peritoneum. If there is a peritonitis in and around the region of the diaphragm, for example, in case of acute cholecystitis, you may get a pain referred to the shoulder tip on the right side. In pelvis, you may get marked tenderness when you attempt a thoracic examination or a pervaginal examination. Now, what is the cause of this localized peritonitis? It could resolve, it may turn into an abscess, or it may lead to a diffuse peritonitis. Now, what happens in a diffuse or a generalized peritonitis? In early cases, you get severe abdominal pain, vomiting, generalized tenderness, generalized guarding and rigidity. The pulse rate is going high, the temperature may be normal, or sometimes may go high and sometimes even be normal. When you get a pelvic peritonitis, the urinary symptoms, because of the irritation of the urinary bladder, because of the irritation of the colon, you may get low stools or diarrhea, tenderness on prorectal or pervaginal examination, and once sepsis sets in, the bowel sounds will be decreased or might be absent. happens in the late stages because of the sepsis. The neural impulses will be less onto the bowel. This will lead to slowing of peristalsis, paralytic areas, resulting in abdominal distension, more of fluid loss into the third space, producing hypovolemia, leading to cold, clammy extremities, sunken eyes, dry tongue, dry skin, loss of turgor, and steady pulse, leading to circulatory failure. The classical facies described in peritonitis is the Hippocratic facies, where the patient himself is withdrawn or might be having an anxious face. And in severe case of sepsis, the patient may go into altered sensorium and even to unconsciousness. Now, how will you investigate? The most important thing is a thorough history taking and clinical examination. Now you get to see what is the total count. Usually it is increased, unless in severe sepsis it is increased. In severe sepsis, what happens is there might be a bone marrow suppression and the patient might have a low count. A diagnostic peritoneal aspiration, you may get to see either blood, pus or bile. Now when you search for the cause for peritonitis, it's mostly secondary peritonitis, especially in a patient who is a smoker, who is an alcoholic, with an upper abdominal pain, diffuse gardenitis. When you suspect a gastric perforation or a duodenal perforation, the first investigation you sought for is usually an X-ray of the abdomen, both erect and supine, where you may detect the gas under the diaphragm, or we call it the pneumoperitoneum. Ultrasound to find out the presence of fluid in the peritoneal cavity, the peristalsis, and other organs, especially solid organs. Serum amylase, and amylase, and not only amylase and lipase is an indicator of acute pancreatitis. And CT scan is usually the investigation of choice in acute pancreatitis. So treatment is usually whether you go for early surgery or wait and watch. It depends on the cause for peritonitis. The most important thing is because of the enormous amount of third space loss, fluid loss. The most important thing is correction of hypovolemia. Maintain an adequate urine output. So general care and specific treatment of the cause with peritoneal lavage if you are opening the abdomen. So what do you mean by general care? I mentioned correction of circulatory volume and electrolyte imbalance. You put in a wireless tube and decompress the gastrointestinal system. Start on antibiotics. Correct the fluid loss to maintain a good urine output. Analgesia before and after surgery to prevent pulmonary complications, as well as DVT, and the vital system support, both the cardiac, the renal, and the pulmonary. Inotropic support if required to maintain a proper urine output. Now, treatment of the cause, maybe surgery or non-operative management, as in pancreatitis, salpingitis, or primary peritonitis. It's very important you give a peritoneal lavage at the end of the operation and should not disseminate the infection. That care should be taken when you give a peritoneal lavage. Regarding the prognosis and the complications. With the modern treatment, the mortality is only 10%. The patient may go in for a lot of abdominal as well as systemic complications. Most importantly, the systemic complications include septic shock, acute respiratory distress syndrome related to respiratory failure, renal failure, bone marrow suppression, and multi-organ dysfunction. Abdominal complications may be a prolonged paralytic ileus, intestinal obstruction and adhesions, abdominal and pelvic abscesses, portal pyemia or liver abscess. And most importantly, wound infection, surgical site infection. Now, what are the sites of abdominal abscess? You can get an abdominal abscess in different anatomical locations, like pelvic abscess is most common, subphrenic abscess, paracolic, right leg fossa, and other regions like the lesser sac, the subhepatic, like that. Now, what are the symptoms of an abdominal abscess? The patient will be having malaise, sweating, anorexia, loss of weight, abdominal pelvic pain, and low-grade swinging fever. And sometimes because of the local irritation, especially when you have got a subhepatic or a subphrenic collection, the patient can have irritation of the phrenic nerve resulting in hiccups. Because of the irritation of the colon, it may lead to profuse mucus discharge leading to diarrhea. So on examination, you see the patient has got an increased pulse rate, tachycardia, increased total count, and localized tenderness. And you may even get a palpable mass. So how will you assess the mass? The assessment is clinical and imaging by ultrasound or CT scan. So you start the patient on antibiotics. If the collection is small, you assess whether the collection is getting resolved. So if it is not getting resolved, the treatment is drainage, either a MAGE-guided drainage or a laparoscopic drainage or even an open drainage. So pelvic abscess is the most common site of intraperitoneal abscess. The causes could be secondary to appendicitis or a fallopian tube infection, salpingitis, or sequelae of a diffuse peritonitis or an anastomotic breakdown. Clinical features, again, loose stools, passage of mucus, especially first time in a patient recovering from peritonitis is pathognomic. And on examination, you see a bulging or bulkiness anteriorly to the rectum. It is soft cystic in consistency when you attempt a PR. The treatment is drainage, either rectal or via vaginal or maybe even suprapubic drainage by getting an ultrasound guidance or a CT guidance, or else you go for a laparoscopic or laparotomic approach. Now coming to subphrenic abscess. Subphrenic means below the diaphragm. Coming to the anatomy, there are 4 intraperitoneal and 3 extraperitoneal spaces in total. The 4 intraperitoneal are left subphrenic, right subphrenic, left subhepatic, and right subhepatic. The 3 extraperitoneal spaces are 2 perinephric spaces and 1 midline retroperitoneal, and that is the bare area of the liver. So you see a coronal section the cross section. So you see a left superior space, that is anterior to the stomach. You see a left inferior space that is posterior to the stomach, that is the lesser sac. You see a right superior space which becomes shut off by adhesions, and a right inferior space. So you have spaces 1, 2, 3, 4. So in the sagittal section you see there is a left superior space called the left subphrenic space. You have a left inferior space, that is the left subhepatic space, and you have the right superior or the anterior abscess, it is called the right subphrenic. This thick black line is the diaphragm. So this is the right subphrenic space, and here you see the right inferior and posterior abscess, that is the right subhepatic or the Morrison's pouch. So what are the boundaries of the left subphrenic space? Subphrenic, isn't it? So that means below the diaphragm. So above you get the diaphragm, below and behind you have the left triangular ligament, the left lobe of the liver, the gastrohepatic omentum, and the anterior surface of the stomach. Whereas to the right you have the falciform ligament between the two lobes of the liver going and attaching to the anterior wall of the abdomen. And to the left you have the spleen, the gastrosplenic omentum, and the diaphragm. Now what are the causes for a left subphrenic abscess? It could be operations on the stomach, spleen, tail of the pancreas, or splenic flexure. Secondary to any of these operations, there can be a collection in the left subphrenic space. Now left inferior or posterior intraperitoneal or the left subhepatic space, it is called the lesser sac. The causes could be, most commonly you get a collection following a complicated acute pancreatitis. Coming to the right subphrenic space, right subphrenic, again below the diaphragm on the right side you have boundaries as diaphragm above, below you have the liver, the right lobe of the liver, posteriorly you have the anterior layer of the coronary ligament and the right triangular ligament. To the left you have the falciform ligament. So what are the causes for abscess in the subphrenic region? It could be a perforated cholecystitis, a perforated duodenal ulcer, or an appendicitis, or even a blowout of the duodenum. Appendicitis more often causes abscess more towards the right leg fossa and the pelvis. Now the deepest space is the right subhepatic space. This is the most common site of the subphrenic abscess. So the boundaries are: right you have the right lobe of liver, the diaphragm. The left you have the epiploic foramen or the foramen of Winslow and the duodenum. Above you have the liver, below you get the transverse colon and the hepatic flexure. Anteriorly you have the liver and gallbladder, and behind you have upper part of right kidney and the diaphragm. So that is a space. This is the most common site for the subphrenic abscess. Causes for abscess or appendicitis, cholecystitis, perforated duodenal ulcer, or even an upper abdominal surgery. Anything of these can produce, most commonly it is cholecystitis or perforated duodenal ulcer, or any complications following an upper abdominal surgery, especially duodenal blowout. So this can produce abscess in the right subhepatic space, the Morrison's pouch. Extraperitoneal spaces, you have right and left extraperitoneal space, and you have the perinephric spaces on either side. You have perinephric abscess, or midline extraperitoneal space, or the bare area of the liver You may get an amoebic or a pyogenic liver abscess. Clinical features could be pus somewhere, pus nowhere, or pus under the diaphragm. So what called by the symptoms? Patient will be having malaise. Patient can be having sweating, wasting, anorexia, epigastric fullness or pain. Because of the irritation of the diaphragm, patient can have pain in the shoulder tip, and because of the irritation of the phrenic nerve, again it can produce hiccups. The signs include running fever, swinging, temperature, tenderness, guarding and rigidity, and a palpable swelling, usually seen in case of an anterior abscess. So the liver will be pushed down, and you examine the chest, you see a sympathetic effusion, collapse, or sometimes empyema. Again, investigations, you see a raised total count, X-ray chest with upper abdomen, you see the diaphragm is tented or pushed up because of the collection. So investigation is always either an ultrasound or CT, or even radio labeled white cell scanning. Most importantly, you do an ultrasound. The differential diagnosis includes a pyelonephritis, amoebic abscess, pulmonary collapse, or a pleural empyema. So treatment is percutaneous drainage, either by ultrasound or CT guided, or else you go for the laparoscopic drainage or even an open drainage. Now coming to the special forms of peritonitis. Peritonitis can be there even in the postoperative period. Postoperative peritonitis. Patients on steroids, biliary peritonitis, or senile patients. The causes could be perforated cholecystitis, post-cholecystectomy following a cystic duct stump leakage or a biliary duct injury. So division of the accessory duct in the GB bed, which results in bile coming into the peritoneum, or a bile duct injury, or sometimes the T2, if you have kept the cystic duct stump into the CBD, might have got dislodged. This will result in biliary peritonitis. Or following other operations like a leakage from a duodenal stump following gastrectomy, or a duodenal stump blowout, or leakage from a biliary enteric anastomosis, or leakage around a percutaneously placed biliary drains. So anything in communication with the biliary tract, if it gets leaked, it produces biliary peritonitis. Meconium peritonitis, usually seen in newborn children, associated with cystic fibrosis, and you get sterile epithelial cells instead of the classical purulent peritonitis. It is sterile, contains mucin, salts, fats and bile, and usually associated with cystic fibrosis. Coming to pneumococcal peritonitis. Pneumococcal peritonitis is a primary peritonitis rising commonly in children, girls between the age of 3 to 6 years, or secondary in case of pneumonia and pyelonephritis. So most often you get abdominal pain, especially in the lower half, fever, vomiting and diarrhea with or without blood staining. Again, counts are raised, more of polymorphs, and you do an operation. You see the exudate. It is odorless and sticky. Primary streptococcal peritonitis of infants and children, the exudate is usually thin and cloudy, and you may get even an idiopathic streptococcal and staphylococcal peritonitis in women using intravaginal tampons. Peritonitis can also develop following an miscarriage, abortion, or parturition, and most often the organism implicated is streptococcus. It can also be present in periodic peritonitis or familial Mediterranean fever. It's commonly seen in Arabs, Armenians, and Jews. So that's about different types of peritonitis: acute, chronic, and different sources, different routes of infection, and different subphrenic spaces and subphrenic abscess and pelvic abscess. Now, another special form of peritonitis is due to tuberculosis, which could be acute or chronic. And chronic can be ascitic, encysted, fibrous, or purulent. In the acute form, you get the straw-colored fluid with the tubercles spread over the peritoneum and omentum, which may show caseation, which is white or yellow. So the fluid is usually sent for bacteriology. Omentum is taken for biopsy, omental biopsy. The piece of omentum is taken, and the abdomen is closed without drain. So fluid is not only sent for bacteriology, it is also sent for examination of different sort of cells, ADA, SAC, all these things are being accounted. So chronic tuberculosis, 90% of the patients will have a dull abdominal pain, 60% presents with fever, another 60% might be having loss of weight, and ascites may be there in another 60%. Night sweats and abdominal mass, these are also symptoms of chronic tuberculosis. The origin of infection in tuberculous peritonitis could be mesenteric lymph nodes, ileocecal tuberculosis, tuberculous biosalpinx, or a blood-borne infection from a pulmonary TB. Now the first form is the ascitic form. As the name indicates, the patient present with ascites. Loss of weight. Appetite loss might be present, might not be present. Pallor. Usually no acute pain, but some sort of discomfort. In examination, because of the protuberant abdomen, you may see dilated tortuous veins over the anterior abdominal wall. You may get a shifting dullness or a rolled up omentum. Diagnosis: you have a Mantoux test, which is supportive, chest X-ray, and most often a laparoscopic biopsy along with an ascitic fluid analysis. The treatment is usually ATT, antituberculous treatment. In the encysted form or the loculated form, you may have a differential diagnosis of a mesenteric cyst or an ovarian cyst. Usually the fluid will be loculated. You may go for a laparoscopy or an open approach with evacuation of fluid and sending the fluid for analysis. In the plastic form or the fibrous form, because of the widespread adhesions, what happens is the intestines, especially the ileum, because most common site is the Peyer's patches of the ileocecal region. The intestines gets matted together, resulting in acute or subacute obstruction. So distant coils of intestine which get adhered together can produce a blind loop, resulting in steatorrhea, wasting, and abdominal pain. So treatment is ATT, and if there is an obstruction, or dense adhesions, you go for adhesiolisis with the resection and anastomoses, sending it for biopsy. And the last one is the purulent form. It's a rare variety in case of tuberculosis. It can be secondary to tuberculosis salpingitis, and the pus from the adnexus might form a mass of adherent intestine, producing a pointing towards the umbilicus, or it may even burst into bowel. Surgery is required if the presenting symptom is intestinal obstruction. We evacuate the pus, but there is always a chance for fecal fistula. So these are the different forms of tuberculous peritonitis. So today we discussed about what is peritonitis, what is the anatomy of the peritoneal cavity, what are the types of peritoneum, the visceral and the parietal, the different types of peritonitis, acute and chronic, the different forms of peritonitis, the different sources of infection, the different routes of spread, the different intraperitoneal spaces, the subphrenic spaces, tuberculous peritonitis, acute and chronic, of the 4 different varieties: ascitic, purulent, plastic or fibrous, the ancestor, and their treatment. Thank you.